So we'll switch gear and move to the CLL field. And let me introduce this clinical case, which is a 72-year-old female patient who was diagnosed with CLL, had a profile which was a little bit mixed with immunoglobulin gene heavy chain being variable regions being mutated, having trisomy 12, a classical phenotype, but has been TP53 mutated. She had lymphocytosis and mild anemia with hemoglobin level at 10.5, platelets at 100, and some lymph nodes and obviously marrow involvement. And she had a mild alteration of creatinine clearance results. So it's a disease that was classified at RISE stage 4, BNA stage C. And the patient was initially monitored because we do know that even the patient with TP53 can sometimes be monitored for a prolonged period. But then she started on bendamustine, rituximab, and obviously the TP53 clone emerged. So she started on venetoclax rituximab as a second-line option and is now progressing after 1.5 years of treatment. So this case, patients that had been treated with bendamustine rituximab and then venetoclax rituximab, options are opened, and really looking forward to both Astrid and Frances's comments about these cases.
Okay, so thank you very much for this invitation. Thank you, Jules, and for the Lymphoma Hub. And I will try to give my perspective from the management point of view of this patient with relapsed refractory CLL from the whole of Latin America. Now, Latin America is a very wide region extending from Mexico to the south of Chile and Argentina, and the inhabitants of Latin America are from a variety of ancestries, ethnic groups, and races. And this makes this region one of the most diverse ethnic composition, region with most diverse ethnic compositions in the world. And each specific country has its own specific ethnic composition. Now, why is this relevant to this topic? Because we know that the incidence of CLL varies within the different races. So in this, this is the result of the SEER trial from the US composition group, and we see that in this trial, Hispanics have 5 to 10-fold lower age-adjusted incidence rate of CLL compared to persons with predominantly European descent. So in many countries of, I'm trying to close this down. Wait a second. Can you, I'm sorry, I think, can you still see my camera?
Everything is all right, yes. That's true.
Okay, I'm sorry. So we can see here this is the result of 5 hematopathology experts looking at more than 1,000 cases of non-Hodgkin lymphoma from Latin America, and we see when this is compared to the cases of North America that diffuse large B-cell lymphoma is has a very high incidence in countries like Guatemala and Peru with almost 50% of the cases, and CLL has a very low incidence. And in some of these countries, especially in the north of South America and in Central America, CLL is a very rare disease. So in the last years, the prognosis of CLL has varied widely with the introduction of new novel agents like these pathway inhibitors, and the prognostic factors have become more and more relevant at time of deciding treatment. And within these prognostic factors, deletion of 17p, TP53 mutation, IGBH status are the most relevant. In Latin America, most of the countries have both public and private healthcare, and there's a wide difference to the accessibility to medical resources within these two different public resources. As we see in many countries, these prognostic factors are available only in a private setting, but still, in almost 50% of the countries, none of these tests will be available for any of the patient. So this also is a big disadvantage for patients. Now, what about the new therapies for CLL in Latin America? Ibrutinib has been approved in most countries, both in relapse and first-line setting, but approval is not the same as being able to receive it. So once again, there's a big difference between the private and the public health system. And the same happens for venetoclax, also approved in relapsed and first-line setting for most countries, but not readily available in the public health system, which is more than 50% of the patients, depending on each country. Now, my previous colleagues suggested that in some of these difficult cases, clinical trials will be a solution. And unfortunately, in Latin America, there are not very many clinical trials. And at the moment, for this patient, for a patient with CLL, there are only a few or a couple of active clinical trials actively recruiting patients with CLL. So now regarding this case, this is a 72-year-old female with mild renal insufficiency who had received a first-line therapy with BR, now has a TP53 mutated CLL, has received venetoclax and rituximab and is now progressing. So there's no doubt that this patient worries me with the resources I have to offer my patients. Now, in the last years, before we used to think of high-risk CLLs as those patients who were refractory to chemoimmunotherapy. But now we have other options, so there's been a redefinition of what is high-risk CLL. And in this paper, Dr. Dreger suggests this new definition, defining high-risk CLL type 1 as those patients who were refractory to chemoimmunotherapy and have a TP53 abnormality. And high-risk type 2 is for those patients who were refractory to chemoimmunotherapy and one of the pathways inhibitors, either BTK inhibitors or venetoclax, and do or do not have TP53 abnormality. Now, our patients would be in the high category 2, but also having TP53 abnormality. Now, these are the published results of patients who had relapsed refractory CLL with 17 deletion 17 p or TP53 abnormality. And this is patients achieve approximately 20% overall response rates, and the duration of response in this specific high group of patients is about 55 to 66% at 2 years, and the 2 years PFS is 51% in this pooled prospective trial. So it's not surprising that this patient is now relapsing. Now, we could think that this patient could also have an opportunity with cellular immunotherapy, but in where I work and in most of Latin American countries, a patient with 72 years that have a mild renal insufficiency would not be considered a good candidate for other transplant regarding treatment-related mortality. And we know, and we have been learning about the enthusiastic results of CAR T cells in CLL, but as said before, this is not approved, and we have no clinical trials available in most countries of Latin America regarding CAR T cells. So looking at this tree algorithm and considering our patient is high risk too, the options would be to alternate the pathway inhibitors, and this patient is ineligible for allo or CAR T cells, so we can only continue with another pathway inhibitors until progression of disease. So what pathway inhibitor could I choose? Definitely in a patient who has not received ibrutinib, this would be my first way of thinking. So what if this patient receives ibrutinib? Ibrutinib has shown very good results for all patients, but the deletion or the mutation of TP53 facilitates the development of other mutations conferring resistance to ibrutinib. So although results are good, they are not as good as for the general population without this mutation. Also, we have to consider that this patient is not receiving ibrutinib as first line or as second line, but has already received 2 lines of therapy. So we see that this is a good option, but the curve, which is the dotted orange curve, lowers down and compared to those patients that received only 1 line of therapy. Now, are learning about the results of ibrutinib in patients who receive venetoclax. We have a lot more experience on results of venetoclax in patients who receive first line or second line with ibrutinib. And this is one published experience, and this is patients with ibrutinib, a second pathway inhibitors, 67 patients, of which 40% had deletion of 17p and 37% progressed monotherapy. And it is interesting to see that most of the patients who progress monotherapy with venetoclax progress due to Richter transformation. Here we see this in more detail. Most of the patients, and we see that in the top lines, progressed due to transformation to other Hodgkin lymphoma or diffuse large B-cell lymphoma, and only a few of them progressed due to progressive CLL. Something important here is that we see that the green line, which are very short for this group of patients, is the time interval between progressive disease and the need of a next therapy. So actually, we should really start thinking about the next therapy in this patient who is progressing. And in the curves, we see that the overall survival for these patients in the blue curve, although there are very few patients, is really very dismal. So this is an unmet medical need when we don't have any other options. What about this patient having a mild renal disease? Well, when offering ibrutinib, we should do no dose adjustment for this patient, and only for patients with severe renal impairment, we should monitor closely for toxicity. So my option would first be ibrutinib, and this is a well-established and potent treatment for CLL. However, we know that for many patients, adverse events are a reason for discontinuation, and this is the main reason why many patients don't get long-term benefit. So I should also think of acalabrutinib, which inhibits BTK more selectively than ibrutinib, and demonstrating very good activity and with less off-target adverse events. And the patients included in this trial had clearance more than 30 millimeters per minute. And these are the published results of retrospective analysis of acalabrutinib in a real-world experience. And we see that from the total of these patients, almost 50% of them had some adverse prognostic factors. There were 22% with deletion of 17p, 24% with TP53 mutation, and 31% with a complex karyotype, and still PFS and overall survival at 1 or 2 years were very good. Which of them is better, we still don't know, and we are waiting for the results of this very interesting trial, the ELEVATE CLL relapsed refractory trial, which is going to include patients who have either 17p or 11q deletion, who have active disease requiring treatment, have received more than one line of therapy. So we will wait for these results to see which one would be best to choose. What about combination therapies? These are a very good option, trying to combine drugs that allow us to achieve a negative minimal residual disease and maybe a limited time treatment. But most of these include venetoclax and anti-CD20, so would not be an option for this patient and are not yet approved in our country. So regarding this case, with the options I have to offer, this patient worries me. I think she doesn't have a long-term prognosis, but I would suggest ibrutinib as third-line therapy, and I considered acalabrutinib if available. And I think this is in line with the international recommendations, especially with this well-known publication of Dr. Halleck, showing that patients who are relapsing after one pathway inhibitor can change to another pathway inhibitor. So thank you very much, and I will see my colleagues' opinion.